Good morning, good morning, good morning, good morning, and welcome to another session. Sorry, we have a little bit of feedback. Okay, let's try that again. There we go. Good morning, good morning, good morning, good morning, and welcome to another session of continuing medical education brought to you by your Department of Continuing Medical Education. I am so happy and excited to have each and every one of you here today. Before we begin, let us open with a word of prayer. Father God in heaven, we come before you this morning, thanking you so much for allowing us to see this another beautiful day, another wonderful opportunity to learn and to grow as physicians, as healthcare professionals. We don't take these opportunities lightly, oh God. We pray that you open our minds, that we are able to receive the information that we will receive from our presenter today. We thank you in all things, praise you in all things. This I pray in Jesus' name. Amen. Well, we are in another month, the month of February, the month of love, the month of hearts. February is Heart Recognition Month, so we are going to be bringing to you matters of the heart. We will bring to you a cardiology series this month, and we hope that you join us for both of our sessions. Our speaker this morning is Dr. Rogeolle L. Morris. She is an internist, adult cardiologist, and cardiac electrophysiologist who recently completed advanced fellowships in adult cardiology and electrophysiology at the University of Toronto, Canada. She is passionate about strengthening cardiac care across the Caribbean through clinical innovation, education, and research. Her professional interests include device therapy, arrhythmia ablation, and cardiovascular health in resource limited settings. Dr. Morris is committed to becoming a regional leader in electrophysiology, advancing academic collaboration, and fostering sustainable access to advanced cardiovascular care throughout the Caribbean and beyond. So, without further ado, please welcome Dr. Rogeolle Morris, who will be speaking to us this morning on coronary artery disease in the young. Dr. Morris?
Thank you for the warm welcome. It's a pleasure to be here in Heart Health Month. Just coming to chat with you about coronary artery disease today in the young. I'm just going to share my slides shortly. Can everyone see that?
Yes, we can.
Is it on presenter mode or you can just see the slides?
No, you're not in presenter's mode. You can make
Okay.
it a bit larger.
Better?
Yes.
Okay. So today I'm going to talk to you about two cases that I had recently, both at Princess Margaret Hospital. And it's something that for me, I'm kind of passionate about because I find that we often say that because somebody is young, they might not necessarily have coronary artery disease. And for this presentation, just strictly referring to ischemic heart disease. I know coronary artery disease is quite a broad topic, and specifically just talking about mostly myocardial infarctions and ischemic cardiomyopathies. That's really what my topic is going to be focused on today, because coronary artery disease can also be things like Kawasaki disease, and things that specifically can cause inflammation to the coronary arteries. But today we're just going to kind of focus on that. So I'm going to kind of take you through some cases. The main aim is not for this to be a didactic lecture, but just to kind of give you an idea as to how you should approach cases like this so that we don't miss anything. And so we improve outcomes for our patients. So it's just to go through recognizing patterns for coronary disease in the young, understanding what the risk factors are. The risk factors are just a little bit different for those who are younger versus those who are older, and how we can apply my real clinical practice in terms of what I've experienced to your practice as well. So who is young? So this is anybody who's 40 to 45 or even younger, and they're often perceived as being low risk. So it's a rising tide in a younger cohort, in that before we used to see that coronary artery disease or ischemic heart disease used to more likely be a disease of the young, of the old, sorry. But now there's rising trends and the incidence of coronary disease is actually increasing in younger populations. And the question is why? Is this genetic related? Is this related to underlying comorbidities? And the challenge with this is that it can impact somebody's morbidity for a very long time, because generally what happens is that they, at their peak and productive years, they get coronary disease, which impacts their morbidity over time and their quality of life. So approximately 10% of acute myocardial infarction admissions are actually under 45 years old. And this means that there are a lot of quality of life is actually reduced because there are a lot of years of life lost, quote unquote. And this can impact an economy significantly, because these patients require follow-up long term. And as opposed to if you had someone who had an MI at age 70 and they died in their 80s, that's about 10 years or 15 years, versus someone who develops ischemic heart disease at 45 and they die maybe at 60, and that's about 20 years, or even if they die at 70, about 30 years, give or take. And I find that this is an under-recognized disease. And for me, I was kind of shocked in these two cases, just because these look like relatively well healthy young men. And, they had a rough time because they almost had some misdiagnoses. So the myth is that young people are protected. Atherosclerosis, unfortunately, does start early though, especially if there is some genetic predisposition. So we're talking about this process starting even as young as your children. Atherosclerosis can start. And then presentation for young people is often atypical. And I'm going to kind of go through that today. So risk factors, very similar for older people, dyslipidemia, smoking, obesity, diabetes, you have family history, so there's some genetic predisposition. And the hidden problem is that a lot of them get diagnosed with their diabetes, their dyslipidemia, their hypertension when they come in with their MI for the first time, which is a big problem as it relates to primary prevention. So how do we escape the trap? The thing is, we need to recognize that we have to say, what is the pretest probability and likelihood of this being the case versus what the patients come in with, what they present with. Just because somebody comes in and because they're 30 years old, they're 39 years old, does not necessarily mean that they can't have coronary disease. So we need to kind of take away a bit of our biases so that we can do justice to our patients. So how do people with acute myocardial infarctions present? In the young, they come in with STEMIs and STEMIs, ventricular arrhythmias. They can even present with heart failure. And their symptoms can be acute versus progressional over time. And I'll kind of go through that in two cases. So the challenge, well, not the challenges, but if you look at a study that was done, it said that pretty much most of patients who are young tend to have what we call single vessel disease versus diffuse or multi-vessel disease in the young. And most of them present with STEMIs, about 57%. And their culprit lesion is usually the most significant one, which is the left anterior descending artery. About 77% of patients will present with that, which is, not a great thing. We often recognize that. The LAD was recognized as the widowmaker, and is that for a reason because again, it supplies a large territory, a large area of the heart. So again, younger, you have more focal disease, mostly affecting the left anterior descending artery. Older people have more diffuse multivessel disease. So this first case was a 42-year-old guy who actually presented to the emergency room with palpitations. He had no known history of hypertension, diabetes, or a prior cardiac history. He had no family history of sudden cardiac death, no family history of coronary artery disease or cardiac disease in general. And when he presented with a wide complex tachycardia. At that point in time, he was electrically cardioverted and he was labeled as a supraventricular tachycardia. And this was his ECG. So you can see a pretty quick wide complex tachycardia. It almost looks like it could be polymorphic in nature, but for the most part, it probably is monomorphic. And my thought when I first saw this was that this was, in fact, ventricular tachycardia and not supraventricular tachycardia. So I actually got a call from one of my residents saying, "Hey, Dr. Morris, I had this patient came in overnight. The team was actually thinking of discharging him from hospital. And she just wanted to run the ECG by me. Immediately, I went to see the patient and I looked at the ECG and this was it. And I said, absolutely not. I think this is VT, even though he's 42 years old. Yes, it could be SVT, but I think for me, I always say when you see a wide complex tachycardia is VT until proven otherwise. And I think for me as an electrophysiologist, a lot of us, I have long discussions with my mentors and my colleagues. And sometimes we often think one arrhythmia is another until we actually put the patient into the EP lab where we do electrophysiology studies and we recognize PT was confirmed and he was actually, he stayed into hospital and his evaluation began. And his echocardiogram showed that he had a left ventricular ejection fraction of 25%. and he had regional wall motion abnormalities involving the anterior lateral wall. So my final diagnosis at that point was that this guy probably had an ischemic cardiomyopathy and he was presenting more electrically. So he presented with VT. And my thought process is that he probably had coronary disease for a long time and probably had a scar that presented with ventricular tachycardia. And believe it or not, this is how most of our patients with coronary artery disease actually die. They have VT, they go into VF and they die. And we think it's sudden cardiac death, but really and truly it's because they've had coronary disease for a very long time. So my lesson is that VT often can be the first presentation for coronary disease, and young patients can actually have severe ischemic cardiomyopathies, and if you mislabel them, it delays their care. So this young man started therapy for his ischemic cardiomyopathy. Unfortunately, there was no cath lab available to send him to, and he's still awaiting his coronary angiogram. And hopefully we can see where I believe his disease process is likely related to LAD lesion because he has anterior lateral wall motion abnormalities. But his EF is quite severe. So I don't know if he may have multivessel coronary disease as well. So case 2 is that of a 45-year-old gentleman who I saw in cardiology clinic. He had multiple emergency room admissions for chest pain, and he had troponins done. He had an echo done, which showed normal, or his EF was actually preserved. And he just got to a point where he was in the emergency room every single day. So his symptoms actually started in the summer of last year and continued and progressed to the point where he was unable to work. So he was a construction worker, and eventually he stopped working because he could not move around, because every time he moved around, he had chest pain. He was initially treated as GERD, and then later, luckily, somebody took him seriously when he went to the polyclinic and actually sent him for a CT coronary calcium score. And that shows that there is a serious system delay and could result in disease progression, which we do not want. So for him, his turning point is that he actually got the CT calcium score. And then from the community clinic, he got referred to cardiology clinic. And this showed that he had some disease. His calcium score was 240. So we know that any calcium score that is over 100 is significant. And he had severe disease in both his left anterior descending artery as well as his circumflex. So the coronary calcium score for me, I'm excited about it because I see it as a new screener, because it generally can be done in patients who you're not entirely sure whether or not they have coronary disease, and you just kind of want to rule it in or rule it out. And it's a non-invasive procedure, and it can be done quickly. And then it gives you an idea of standard what their 10-year risk of coronary artery disease is. If you have a calcium score that is 0, then their risk of any events is quite low. But if you have somebody who has a calcium score that is over 100 or 100, their risk of coronary disease as well as coronary heart disease mortality increases 8-fold. And, I've been doing a lot of these since I've come to the Bahamas, because I find that, if you don't have things like an angiogram readily available to you, whether it be because of resources or because of some financial limitation, is actually an easy test to do and not as expensive as a coronary angiogram. Granted, even though it is somewhat to me as a screening test, it kind of just is not the gold standard though. So the gold standard or the ideal would be to do a coronary angiogram eventually if you do find somebody who has a calcium score that is higher. I think that is a beautiful test, especially for younger people. For older people, not so much. So once you reach maybe like 70, 75, generally our calcium scores start to go up as we age. So it's not a good screening test for older population. It's also not a good screening test for patients who have chronic kidney disease, because of their history of secondary and tertiary hyperparathyroidism. they also have an increased risk of calcium deposits. But just bear in mind that patients with chronic kidney disease, they have a fourfold increased risk of having ischemic heart disease as well. So they have a high mortality as it relates to coronary disease. So how do we make a decision as to who to send for coronary calcium scores? If you have a patient, again, young, we're talking about coronary artery disease in the young, they have a family history of premature coronary artery disease, or they have multiple risk factors, I generally would send them for a coronary calcium score. And there are also some patients who, so I had a young lady who came to me, she's only 47 years old. Her father died at 47, and she came being concerned about the possibility of her developing MI as well. So her dad had a massive heart attack and passed away on the same day. So for her, that was her turning point where she said, you know, I don't want to be like my dad. So she was sent for a coronary calcium score. So just awaiting those results. But generally, once you have a score that's 0, then going forward is just lifestyle management and primary prevention. If this is somebody who has a calcium score that's greater than 0, regardless of if it's 1 or 2, the aim is to make sure that you aggressively manage their blood pressures, aggressively manage their comorbidities to prevent them from progressing, especially if the person is diabetic. You want to be extremely aggressive in those cases. So the outcomes are both of those patients were referred for coronary angiography, and we'll wait to see what their coronary journey of other things that are often missed. So there's this mystery of a disease entity called myocardial infarction with non-obstructive coronary disease. So there's some form of electrocardiography evidence that the person had an MI. But when you do a coronary angiogram, it is completely clear, clean, no evidence of atherosclerosis, and it is prevalent in about 15% of patients who are young who present with acute myocardial infarctions. The mechanisms that, or the hypotheses that have been proposed, is that it may be related to microvascular dysfunction or coronary vasospasms. But the clinical pearl is that clean arteries do not always relate to no heart attack. So that's something that we need to be aware of. So is Minoka is not benign, and it requires structured evaluation, just like how you would evaluate somebody with an acute MI. And generally what I do is I kind of treat these patients quite similar, and there may be some other medications that I add as well. For example, we can add nitrates. We can also add our calcium channel blockers for these patients for their microvascular dysfunction. But generally, these patients kind of get treated similarly for patients as along like patients who have ischemic heart disease. There's also this entity called spontaneous coronary artery dissection. It's very common in young women, especially in the postpartum period. We actually had a case very early on when I first came to PMH of a young lady who had delivered, and she had a troponin that was significantly elevated. There was no ECG changes to suggest that she had a myocardial infarction. And, you know, one differential that we thought of was that she could have SCAD. So SCAD is a real thing. And again, there's also some prevalence in women who are older, but it's mostly common in women. But it could also present in the postpartum period as stated. And the management is a bit different. You don't do coronary stenting for these patients. These patients, you kind of monitor closely. Most of them can require statins and aspirin. Sometimes people put them on dual antiplatelet therapy for a short period of time. And then sometimes you can also check for other things as well. So generally the angiogram should be done because it's a diagnosis of exclusion. So an angiogram shows that there's a dissection of one or more of the coronary arteries. So this shows the left anterior descending artery with some septal branches and diagonal branches. And there is a dissection within the arrows that are pointed. So why is coronary disease often missed? There's age bias. There's also anchoring and delayed imaging as well. So the cause of diagnostic delay can result in a psychological distress and uncertainty for our patients. And we have to realize that patients, this is their peak workforce, and it can potentially cause an economic burden during their most productive years. So prevention in the young saves decades, not just years. So, how do we bridge the gap? How do we prevent failure of diagnosing patients who have risk factors for coronary disease and also missed screening? I actually saw a young gentleman yesterday in my office. He came for clearance, cardiac clearance to have insurance. And I was having a conversation with him, and he said, I'm fit, I'm fine. And clearly, he, in my mind, was overweight, he was obese. And I said, have you ever had your cholesterol done? Have you ever had your lab test done? And his answer was that I never even knew that I could get my cholesterol checked. And he actually had evidence of xanthelasmas over his eyes. And I said, his cholesterol is probably high. But when I was chatting with him, he thought that I was being over the top of sending him for all these investigations. But it's just to say that we need to start having conversations with patients, whether to educate them in the primary practice so that they understand that screening starts younger and not just when something happens. So for these two cases, same disease, but different presentations. One presented kind of electrically, the other one was more of a atypical type chest pain, but same underlying coronary artery disease. So how do we manage these patients and how do we improve our systems of care? The thing is that coronary disease in the young is a system disease problem. So we need to start with primary prevention. We need to do community and education to recognize that this entity exists so that patients can be aware. And we also need to do better inpatient and cath lab care and long-term secondary prevention. So primary prevention, when should we start? Start young, talking about 30s, 40s. And this gives us an opportunity before they even get their first MI. And we need to do lipid screening, diabetes screening, chat about smoking cessation, and also recognize what family dynamics exist or what genetics exist. So any high-risk young patient should be screened, and we're talking about patients AV nodal dysfunction or even sinus nodal dysfunction. Their first presentation is make sure you do serial ECGs, continue with troponins, and always have a low threshold for referral. So obviously for STEMIs, you need to immediately reperfuse them. And we need to find a good pathway, especially in our system where we don't have coronary angiography readily available to us. But at least we have fibrinolytics, which we use for STEMI management. And then obviously, they can have what is called bridging therapy, where they get fibrinolytics until they get to a center where they can have PCI. So NSTEMI for me, I treat NSTEMIs the same way because for me, it's the same underlying process, which is atherosclerosis. So for me, I do early invasive therapy. I like that. So anybody who comes in with an NSTEMI, I often prefer that they go to the cath lab within 24 to 48 hours. And you need to risk stratify these patients, see which ones should go to the cath lab first. So if they have heart failure, if they have hemodynamic instability, you need to stabilize them first and then get them their coronary angiograms. Because even though they're in STEMIs, they still have significant coronary disease. And especially if they have refractory symptoms. So you've treated them, you've managed them, you've given them dual antiplatelet therapy, you put them on clexane or heparin, you've done all that you have done, but yeah, they're still symptomatic, still having chest pain, troponins are still rising. Those persons should go to the cath lab immediately. So I think a lot of people don't recognize that VT can be the first presentation, and even patients coming with frequent ventricular ectopy Sometimes that can be a new ischemic cardiomyopathy. And just don't stop at stabilizing. So we stabilize the patients, we get them where they need to be, they're chest pain free, but they still need echoes, they still need coronary angiograms, and they still need to have their risk factors dealt with appropriately to prevent other MIs and basically early secondary prevention. In terms of SCAD, as I said, it's usually conservative. You definitely avoid stenting, but there's usually a multidisciplinary approach and follow-up. And then you also want to counsel them about future pregnancies because once you've had SCAD in one pregnancy, you could have it in others. So we need to look at long-term management and then continue with high-intensity statins, antiplatelet therapies, as stated before, manage their blood pressure, have adequate glycemic control, and most importantly, lifestyle modification. And early LDL reduction matters because you have decades of exposure to high LDL results in advanced atherosclerosis. And if you try to get the LDL reduced quickly, then you can reduce any myocardial events occurring. A lot of people don't do cardiac rehab, which is not good because cardiac rehab is very, very, very underutilized and very important in young people. And this allows them to return to who they were before. And I think that coronary disease affects younger people psychologically more than older people, and they need a lot of psychological support and assistance with returning back to work. And that is something that cardiac rehab can offer you. So when discharging somebody with coronary disease in the young, you intensity statins, both their blood pressures and diabetes are well controlled. We talk about a smoking cessation plan if they are smoking and refer them for cardiac rehab. And then obviously book close follow-up with a cardiologist. And I think these system gaps are across the continuum. So primary prevention, secondary prevention. The issue is a lot of late screening, just because there is an age bias and we need to bridge those gaps early. And we need to find an ideal pathway, do early risk stratification, think about doing testing, screening testing like coronary calcium scores, so that we can impact the lives of our patients. So this is generally is because you're young doesn't necessarily mean that you're low risk. And persistent symptoms always should have escalation of care or looking closely into what their presentation is so that we can evaluate them properly. And one takeaway is that most times I say is VT until proven otherwise when you see a wide complex tachycardia, especially for that case, because that guy almost went home with the EF of 25%. And what could have happened? He probably could have died at home with another VT episode. So, in summary, I think we need to understand that our younger people are a little different and we need to understand the anatomy. Most times, these patients have single vessel coronary disease. If they do have diabetes, especially type 1, they could also have multivessel disease. And coronary calcium scoring should be used as a useful tool. And we should take away any biases associated with young people having coronary disease. So that is my presentation. And thank you for joining me. And these are my references. Any questions, comments? Happy to have them.
Thank you so much, Dr. Morris, for that wonderful presentation. There were definitely two very interesting cases that you brought forth. Oftentimes, when we think of any cardiac pathology, we would normally think of the older individuals, but you have clearly highlighted and demonstrated to us that we should definitely have that in the back of our head, even with younger patients. And thank you for highlighting the importance of ensuring that all patients have primary care. and that they are receiving the necessary screenings that can help detect and allow for early treatment of any cardiac pathologies. The floor is open for any question or comments. We have a comment. Good morning. Great presentation. How long does it take to get calcium scoring results? And the
I I don't know publicly, but I feel like it's quite easy to get them. The cost is about $2,500. Most of my patients in the public practice, they took about a week to get theirs. Privately, you can get yours in a couple days. So it's readily available. I think we just need to know where to send our patients.
okay. Further to that, the patient you spoke of, did he also get other team management from nutritionists, psychology, etc.?
So my none of them got any nutrition involved or psychology. And I think that that's a great comment because I think both of them needed that. Especially the gentleman who came with recurrent episodes of chest pain. And I think for me, one thing that stood out when I saw him in clinic, I actually admitted him to hospital because I thought he had kind of refractory unstable angina, was that he said, you're the only person who took me seriously. So I think we need to, take our patients a little more seriously, listen to them carefully. And again, I agree with a multidisciplinary approach to their management. Nutrition is very important, psychology. And I think that's why I stressed on cardiac rehab, because cardiac rehab can provide both nutritional support as well as psychological support. So I think it's something that um, we need to provide for to our patients.
Okay, thank you. I recognize your hand, Dr. Griffith Bow. You can go ahead.
Thank you. Good morning. Can you hear me?
Morning, yes, please.
Great. Good morning. Awesome presentation. So my question may seem um, rather simplistic for you, but it oftentimes poses a bit of a challenge for me. So I would see women primarily in primary care, some pregnant, some non-pregnant, and they would have asymptomatic cardiac murmurs that I would auscultate during my routine physical examinations. And so I always wonder, do I have to escalate asymptomatic cardiac murmurs to cardiology? Should I just do a routine ECG? How should I go ahead and manage these patients? Because I do not know if this may lead to something more significant in the future.
Yeah,
Thank
thank
you.
you for that comment. And I'm just going to give you an example. So I saw another case, a great case. This was a young lady who was perfectly asymptomatic, and she actually saw her primary care physician for asthma, and he sent her for a CT chest because she was having some chest pain and some shortness of breath. So he thought it was related to her asthma. Long story short, the CT showed that she had some calcium deposits on her aortic valve. He sent her to me. I saw her. She actually had a murmur. I sent her for echo, and her echo showed that she had severe aortic regurgitation, and she was completely asymptomatic. And she had evidence of what they thought to be one of her aortic valve, the non-coronary cusp, I believe, was prolapsed. So there was malcoaptation of her aorta. Long story short, I always have a very low threshold for sending people for echoes. I feel like it is an easy test to do. It may not necessarily be readily available, but I feel like it's something that is easy. So I kind of, and I don't have a problem seeing patients as well like that. So if you send them with a murmur, I'm happy to see them, happy to do echo, because I think it's low yield and it could give great information.
Thank you.
Okay, thank you for that. We have some additional comments and question in the chat. Very informative presentation. Good morning. I thoroughly enjoyed your presentation. Very informative. Is the calcium score available at all CT radiology centers, or does it require?
Yeah, I'm not sure how to answer that, but I think it does require a so I think that that's what's generally required. But I think most radiologists are trained in reading CT calcium scores. Um, yeah, but good question.
Okay, we have some additional comments, but we do have two hands or two individuals who wish to speak. Dr. Ramphal and Dr. Leville. You can go ahead, Dr. Ramphal.
Okay, hi, can you hear me?
Yes, please.
Yes, we
Morning.
can hear
Okay,
you.
good. Thanks for the great presentation. Um, just my question, I'll ask it at the end, but just to answer some of these things up there in the comments, there are multiple cath labs in the region, if the region consists of the Caribbean and the English-speaking Caribbean, and we had cath lab at Doctors Hospital up until a couple of years ago that was functional and is now being renovated. So we'll soon have cath lab facilities.
It's now opened.
It's just opened. Yeah, it's not
Yes.
fully functional. They're going through their sort of few weeks. It should be operational fully. Um, But that does not mean to say that after all this time, PMH should be looking at doing their own cath lab. I think that that's something that should be looked at in the Department of Medicine and in cardiology especially. I don't know how that's going to happen anytime soon, but really PMH should be looking to get their own cath lab capabilities going at some point. But in the Bahamas, there is a cath lab. There usually has been a cath lab. It's just the last couple of years it's been out of commission. But it's a private cath lab, so there's the financial problem associated with that in many cases. My comment or question really was just for clarification. As an old man getting ready to soon see the back, to wave goodbye to everybody in the next few years. Maybe it's a new thing, but you use the term when you were talking about diagnostic problems with these patients. You used the term anchoring as one of the problems, and I'm not familiar with that term. Can you explain it to me, please?
I think anchoring is more understanding that, these patients should not be dismissed. So that's more or less what that meant. So we need to listen more to their problems, their challenges, and what they're coming with, and then base what their presentation is in terms of how we either approach their management, how we investigate them, and how we manage them in general. So that was more of my reason for using that terminology, more or less.
Okay, thank you.
Thank you, Dr. Ramphal. You can go ahead, Dr. Leville.
Good morning, Dr. Morris. Very
Morning.
useful presentation. I really enjoyed it and hope to take advantage of it. One question I had, I know you mentioned in screening the young that we should look at their risk factors, including smoking. Now, recently there has been, I think the cigarette smoking is more or less stable in the population, but the marijuana smoking has gone up exponentially. We have people, teenagers, young people, smoking quite a bit, between 3 to 8 joints per day routinely. So does that increase the cardiovascular risk, atherosclerotic risk as well? And should we also be just as adamant in advising patients regarding that?
Yes, most definitely. Yes, so it does result in advanced atherosclerosis. And I think there is more or less like a 2 to 3-fold increased risk when it comes to coronary artery disease when you compare smoking cigarettes with tobacco versus cannabis. So it's something we generally should be asking our patients all the time. And also about cocaine and any other
Yes.
drug use as well, right? because I think for me, we're trained in Toronto, cocaine was very easy to come by. And, I've seen a lot of patients who are actually coming with coronary vasospasms and even VT and arresting after using cocaine. So it's generally something that you often should ask about, especially cannabis in our population. But I think Dr. Cooper is also making that comment in the chat as well. But yes, we should be specifically asking about cannabis and their history and how long they've been using it. And yes, we do have a few cath labs in the region.
Thank you.
Thank you.
Okay, thank you. Yes, Dr.
I think
Cooper
Dr.
did.
Rampal wants to say
Yeah.
something else.
Hi. Thanks a lot. Sorry. I just one last little comment. This talk raises the reality that we're seeing more young people especially in the Bahamas, I would say, with coronary disease. I would venture to suggest that for almost all of the chronic illnesses, diabetes, hypertension, coronary disease, renal failure, etc., there's all these related spectrum of diseases that are interrelated. I would suggest that in the Bahamas we need to bring forward the expected age range of our patients at least 20 years, because we see very young patients with end stage renal failure in their 20s, blind from diabetes in their 20s and early 30s, and this is not an uncommon thing. And I think that the international or North American, European age ranges for these conditions and their severe consequences and complications really has to be moved up a couple decades for our population. For whatever reason that is, there's probably a genetic component to that, but we are definitely not surprised anymore when we see a 30-year-old diabetic with end-stage renal disease and already starting to lose their sight. And this is something we're seeing very common. I don't know if anybody else who's in internal medicine would want to dispute that or agree with me, but that's definitely the impression I'm getting, that our disease profile is a couple decades earlier than the standard statements.
Yeah, I completely agree. And I think it has a lot to do with genetics, to be honest with you. Um, but yeah, I definitely agree. And for me, even though I've seen it in Barbados, I've also seen it in Jamaica and Trinidad as well. Like I've seen the odd 31-year-old come in with a STEMI. And but really and truly, I think if we had to, I think it also should be studied as well. But if we think about it, I think when we compare ourselves to North America, we definitely have more aggressive disease.
Yes. You wanted to know if your first case alarm have been raised as well as admission. Thank you for that.
Surprised. But funny enough, for this guy, I think he had both. So he came in, had the VT. Actually, this is a bit unconventional, but he was in hospital for at least 2 weeks on amiodarone. And I actually put him on a treadmill before he went home because I was so scared that he would have VT again. But when I put him on the treadmill, he actually had a SVT. So I think he has both. And I think we're just kind of lucky that he had the VT because it would not have caused me to even for once do a echo. For sure. Thank you for that question.
For that.
Thank you.
Do we have any more questions and or comments for Dr. Morris? As you think of your final question or comment, I would like to direct your attention to the chat. The feedback link has been placed. I kindly ask you to ensure that you complete the feedback for this presentation. This is a CME credited presentation. You will be able to claim 1 credit point for this. Also asking that if your name is not written out as you are registered at the Bahamas Medical Council, kindly ensure that you change it so that we can apply the credits for you. We have another comment coming in from Dr. Pinda Butler saying, thank you for a great presentation.
Thank you.
The feedback link has been resent, so you don't have to scroll back too far for it. Kindly complete the feedback link. And if there are no additional questions or comments for Dr. Morris, I'd like to take this time to thank each of you for spending your morning leveling up your knowledge in cardiac health. I would like to extend a special thank you to Dr. Morris for doing her first presentation for the Department of CME. We truly appreciate it, and we welcome your wealth of knowledge, and we look forward to having additional sessions with you. Spoiler alert, last Friday of this month, and we're definitely looking forward to that presentation as well. So we hope to see each of you the last Friday of this month as we continue with our cardiology series in recognition of Heart Month. Have a great day.
Thank you. Thank you for having me. Bye-bye.